I really enjoyed listening to JJ talk about lumbar arthroplasty. I always learned a lot by hearing different perspectives. What I wanted to do is to talk a lot about cases and what I learned from cases, and we'll briefly kind of talk a little bit about the literature when we look at cervical spine and TDR. And I hope you can hear me. I'm not in my office. I just happen to be traveling in Missouri and was trying to find a place for the internet. How do I advance the slide here? Am I doing something wrong? There we go. So I always struggle a little bit when we talk about gold standard, because it's not really a gold standard for any treatments we do in spine. I think the standard of care is what's reasonable, because there's so many reasonable treatments, and we should think about things that are reasonable based upon so many factors, including our experience, the history, the instruments we have, where we live, and a variety of things, rather than just gold standard. But historically, for many, many decades, this is how we manage patients with 1, 2, 3, 4 level cervical spondylitic disease and pathologies, and it's been well known, and we have pretty good underlying conditions of outcomes. I'm not doing great at this. Okay, great. So we've seen a lot of different technologies in arthroplasty. And, this started out with the Prestige, and we started then to see the ProDisc, and then we saw the Bryant, and we saw a variety of these different technologies kind of enhance. Can you hit the slides for me? I must be not doing that right. Okay, good. But then really, there's been an entire plethora of different types of technologies, each of them having a little different fixation method, maybe a little different biomechanics, some of them different actual materials of what we've seen compared to that of the lumbar spine. In North America, we have 2 total discs that are FDA approved that are used clinically currently, which is the ProDisc and the Active-L. And the cervical spine, we have a whole platform of these technologies that we can make decisions on to approve. Next slide. Do I have the power to change this? Okay, good. So do they move? Well, I think it's obviously a lot easier to see this move and the technology move in the cervical spine than that is in the lumbar spine. And the big always question is should you have something that's more mobile, something that unloads the facet joints? And then the key here, though, is it's not as forgiving as the fusion. It's because you have to try to do the best you can to reproduce the axis of rotation so that you can get the motion that you're trying to achieve out of all of these types of technologies, no matter what they are. Oh, I mentioned earlier, I have no conflict of interest of any arthroplasty device, don't own any stocks or have anything regarding this technology. Okay, next slides, please. I must not be doing a great job. Okay, so what I want to cover just briefly, and this is, we have different materials, we have different fixation devices, we have different biomechanics, and then images, and we'll talk a lot then a little bit about cases. Okay, go ahead. So, next slide. Okay, so this became a real problem, is this eclipse, I call it. So when we put these we're used to putting in fusion devices, and we've gained so much on titanium plates and cages and things that allow us to still do advanced imaging of the subaxial cervical spine in the future. But this become a little bit, how this is an eclipse to some extent, where you can't see real well. Next slide. And so, go ahead and hit the next slide. When you put 2 discs in like this is the kind of artifact you see on the far right side, or you get this MRI eclipse. It's sometimes very difficult, no matter what techniques you do, to adequately visualize the spine, and it makes it a little bit of a challenge for us. So we tend to find looking at better technologies, but all of the technologies give us some sort of a major eclipse or artifact associated with this. Go ahead. One. Oh, there it is down there. So this is just a graph of the different types that you can see of the amount of artifact on different MRI slices that we get. And clearly the Bryant and the Prestige ST tend to probably give us just a little bit less than some of the other technologies, but they all give us a pretty major artifact. Okay. Now, this is a new technology I was involved in one of the lead investigators for this technology called Simplify about 5 to 7 years ago. It's a PEEK implant with ceramic fairing in the inside. You can clearly see from the x-rays and from the MRI scan that it gives a really good overall image of the technology without really a big artifact that we've seen before. Now, let's take a look at fixation type. Some of them are screw fixations. The problem with screw fixation devices, you can't change the axis of rotation to decide how to put the implant in further or out further. And that's why the one on the left had a slot in the bottom, because it had to have that variable axis because you had no ability to adjust it. We've also seen devices that have spikes like this that I would consider the Mobi-C, the Cervical, the Discover, and they're all different patent type devices and different ways to fix them. The problem is that we load them and we put too much load to them. This was the patient I saw in consults. Someone had done a fusion and then they put these mobile cores above and below. And you could see it's just asking for too much. When you resect the anterior sphenoid ligament, most of the time you probably resect the posterior sphenoid ligament, and you're putting in a device that I may consider as not a true total disc. It's more of a mechanical nucleus replacement. And when you do that, you can see that the top disc actually, like that, has no secondary support. Probably over-distracted the facet joints. The ALL's gone, the PLL's gone, and this device doesn't have internal stability. So then you get total loss of stability, and that's not what we're trying to achieve, as we can see on the right. Okay, next slide. And then we see some of these implants have heels. They actually do a really good job of anchoring. I personally like the heels in the lumbar spine because, as JJ and I were debating, once the bone heals in front of the heel, that implant's not going to move. And that's the reason the heel doesn't go all the way to the front. And then some of them you see here is a press fit device. Now, they all have problems that I'm going to show you. I've been collecting all the disasters that occur with all of these, including some of mine, over the number of years. Each of them have a little bit different axis of rotation, and you can see how these implants move. The key I worry about these implants is I never really saw good bony ingrowth on the left X-ray, the top superior plate. And so you worry about whether that's really got good ingrowth and is that really moving and is it a good match with the facet joint. But the goals of all of these types of implants are the same as we have for ACDF. It's to decrease the pain, increase the motion, increase the disc space height. Let's talk about adjacent level disease. And does it have a quicker, faster recovery than we normally see with an ACDF? And I think it does. Again, I tend to restrict these patients for a small time. When we do these clinical trials, we learn, as JJ mentioned, more about our fusion data than we probably ever knew. Because historically, we would always say our fusion data for 1 and 2 level cervical fusions is 85 to 90% because the outcome was fusion. Now the outcome isn't fusion, the outcome is function. So we had to run a lot of functional tests, and we know more about the functional improvement, I think, of our fusion patients than we ever did before by running these, which includes the VAS, the Neck Disability Index, SF36. Because remember, the measure of outcome is function, not just fusion. Well, this is a long-term study looking at cervical disc, both 1 and 2 levels, 1,000 patients. And the overall the implication of this study was lower implant adverse effects, better improved functional outcomes, and probably in this study here, this 1,000 patients, a lower adjacent segment disease at the same time. This is one that was published by Dr. Radcliffe in 2017, looking at the Mobi-C device. And I think the general conclusions at 7 years was the composite success rate demonstrated clinical superiority in 2 levels of TDR over ACDF. And I concurred with JJ that the patients with 2-level arthroplasties, I think, tend to do dramatically better than 1. Maybe it's because the patients with 2-level disease, it's been going on for a while, they may have a higher NDI to begin with. And so those are usually much more symptomatic than single-level disease. If they got 2 nerve roots compressed, they've been symptomatic for maybe that's why their improvement tends to be a little better. But we can see the overall patient satisfaction for function is one of those measures of outcome. I published this as a lead article in the JBJS a few years ago, where I followed up our cervical single-level arthroplasty patients with ProDisc for the 7-year follow-up and put that into the JBJS. And some of the keys of this was we were able to get over 90% at 7 years of both groups in the randomized clinical trial, which is, I think, a great follow-up. And from that, we can learn that there was really no deterioration in either one of them in the NDI. And remember, the ODI we tend to use for low back as in all the outcome measures that JJ mentioned, and we're looking for the NDI. I take an NDI on every patient who comes in with neck pain and an ODI at every visit for low back pain. And I think it helps when you're looking at workers' comp and improvements and post-op because we're measuring function. We have to get used to that. Also, there was no deterioration when you look at the baseline of the SF36 in both groups at 7 years. And so, that's probably great outcomes. The same with the VAS for both neck and arm pains. They were really great and high. This, I think, is the key. What we really tend to see is the risk of a secondary surgical procedure in these patients at 7 years. And there was a substantial differential on the patients that had ACDF as their, remember, randomized prospective clinical trial patient, didn't know what they were going to get at 7 years compared to those patients with the arthroplasty group. I think that's been one of the key things, and that gives you the big differential that I tend to tell patients. For me, I think both work great. I think a cervical arthroplasty is a quicker, faster recovery. I don't worry about them after 6 weeks like I do a fusion, because we know the biology is going to take longer. And I think the 5 and 7 year results may have a dramatic improvement in this group of patients. But there are problems with them. We can see all of these are different types of arthroplasties, all performed by excellent surgeons. They all have a little bit different axis of rotation. You can adjust them each a little different. The one on the left, the Pro Disc, you can look at where the axis is compared to the top right, where you can see a press fit. You can't really adjust where that goes. You can see the MobiC at the bottom. But they all can have issues. Look at this one here, was one of them that I found. The patient came back to see me at 7 years post-op from a Simplify. The Simplify, it looks a little over distracted on the left. It's great MRI compatibility, but now look at it. It doesn't look to me on the top, on the third image, that you really look like it's going to function ideal, because the relationship of the end plate to the inferior aspect of the superior end plate clearly has changed where we put it. So either A, there's no great bony ingrowth, B, the facets have allowed it to become hypermobile, and it's sure the X-ray sure scares me just a little bit. But we've also seen, when we first started training lots of surgeons in the last decade and a half, of implants like this, they were put in the less than ideal position. There's a fusion up above. You can see the implant looks like it's into the canal. The axis of rotation wasn't matched real well. And so we can learn, and here's another mixed match, a clear-cut mixed match of a press-fit prosthesis. It looks like the inferior plate or the superior plate of the bone may have been milled a little bit, maybe not opened up enough, and clearly the mechanics of this implant is going to be problematic for reconstructions. And I think we can learn a lot more about looking at these failures and showing you case after case of how things look. So I tend to grab it. This is another case that I think we see subsidence. We see migration to the canal. It became segmentally kyphotic on the left side. The implant probably is in the wrong axis of rotation compared to that of the facet joint. Here's another implant that migrated to the front on the right side, less than ideal. Wasn't the best situation for this patient, and these all need to be revised. And here's a whole series of them. Let's look at the top left. It looks like there's a lot of osteolysis, collapse, hypermobility, segmental kyphosis, and whether this was milled or not milled or what happened, I can't say. Look at the second on the top, and it looks like one of the implants is pushed down into the bone. The other is way too far forward. The bottom left, the implant, you can again see, doesn't look like it's subsided into the bone. Either way, it was over distracted or too much milling. And then the bottom right, again, does not look great in its capacity. All of these are problematic. And again, here's another one that I had a CT scan. We can all see from the top right picture, this implant doesn't belong, 20% into the canal, and you can see that right there. And the bone is all collapsed. You take the ALL out, you take the PLL out, there's probably some milling done. The implant's put in too far on the top right. The set of x-rays on the top left looks like the implant's not quite far enough because it's a mixed match, and that's not going to move. I tell patients, or I tell my fellows, the best way to look at these things is, if you take a door on a wall and there's 3 hinges and you unscrew the middle hinge and you rotate it 10 degrees and screw it back in, it's a mixed match. The door isn't going to open. And we have to look at each one of these segments to figure out where the balance is. Because I think that when you look at the skull and you look at the head and you look whether they got lateral lordosis or not, it's like balancing a bowling ball on a bowling pin. And we can't just look at the segment. We got to look at the overall alignment, or you get exactly these kind of failures and bad judgments. Here's a patient with 2 bad discs. Probably you could say, Mike, it doesn't make a lot of sense. They've got a lot of ossification in the ALL in the front. They were distracted out. I think these are advanced techniques, and you can easily reconstruct them with motion preservation technology if you've got good implates. And I think there's good bone on both of these implates. I put them in tongs and try not to just over distract them. And the most common implants, 5 millimeter, because it needs to be 5 because if it goes into flexion at 6 or 7, if you put a big implant in and stuff it like we'll do a fusion, the implant won't move. So those are keys. Here's an example of just trying to center it. Most of the time you want to center it probably between the oncovertebral joints. You want to look at it and determine I think a two-level arthroplasty is a lot harder, especially in the lumbar spine, than a one, because you're trying to balance two things at one time. When I look at the left x-ray, I look at where the axis of rotation is on the top one, and the bottom one's a little bit further back. I look at the facet joints and see how horizontal they are and try to come up with the best overall plan. I can show you all kinds of bad arthroplasties, but we've also seen these for the last, my career for 30 years, where surgeons made less than ideal judgments for fusion technologies too. And the one on the left is a horrible. And then the surgeon, we started doing plating in the 90s. And you can see this is a very good way we can learn that through that learning curve, we didn't all make the greatest implants. So we used to have collapsing plates and telescoping plates and all of these to try to solve this, or you can see screw breakage. So not just arthroplasty, we've seen these terrible designs like this, or techniques like this for fusion technologies over my career of 30 plus years that are less than ideal. We all know this one on the right is going to fail. It's going to piston, it's going to fail. The plate isn't going to suffice the overall biology in cases like this. But we do get posterior instability issues. Look at this case. And I think there's something happened here. And both of these look like they're in kyphosis. The inferior end plate's falling forward. Maybe it was the mixed match. I don't really see in the coronal view that it's collapsed, but clearly this is not a great overall outcome, and we would all probably think we could have done better. So I think we can learn a lot by looking at and analyzing all of these. What do you do in adjacent level disease? Well, here's a classic example. This is a patient on the left that had a fusion for 2 levels, and that was adjacent level disease. Yes, you could say the plate was a little close and less than 2 millimeters, that disc space. Maybe that's why they got that osteophytic problem compared to doing a 2-level arthroplasty and below there, and I don't see the same disease at the level below. So what do you do in a case like this? Well, I did the fusion, okay? And that's a 2-level fusion I did on my spouse about 12, 15 years ago. And then she ended up with the proximal level disease, as you can see here. And yeah, I probably should, at that time, we didn't have all the technologies. I probably put the plate a little close. Maybe that added to her adjacent level disease. I think this is a great indication for an arthroplasty rather than doing an adjacent level fusion. So I just decompressed her and took the disc out, the plate out, and put an arthroplasty in. And she went on back to do her activities and back to work. And she's, I live with her, so she doesn't complain too much. So I think that's great. But I do think that we expand some of these technologies, and it's not great. I worry about this arthroplasty below this long fusion here. I really worry that this is not going to do well. And the magnitude of the forces, we've seen what happens when we put big grafts in and how they piston in, and you can see this isn't going to work well either. You can see what happened. I had to take that implant out. You can see what happened in this long construct. Even though we can make the x-ray look good, the forces and the magnitude on that is just way too much to be able to get a good outcome. And I don't think this is the best ideal outcome rather than doing proximal, just because the loads on this are huge. We know that the load failure of doing it as a fusion is going to be horrible, and trying to put these technologies in and load it on a plastic isn't going to work well either, and that's the problem. But we've also done non-contiguous diseases where you see patients like this either have a fusion or congenital fusion in the middle, and then sometimes we'll do an arthroplasty. I like to look at each segment and where it's at in the face of the disease. I tell the patient it's like dental disease. If you go to the dentist and he thinks you only need a filling, I can probably do an arthroplasty. If you go to the dentist and you need a crown and a root canal and a major reconstruction, probably needs a fusion, maybe even front and back. So look at each disc of where it's at in the face of the disease, and I think it makes it a lot easier. So we don't end up with cases like this that are ideal and just horrible to have to unfortunately revise. Multi-levels, I think, are a good option in closing, and we can do, but it's a balance, and the balance is everything. And I think that you can see the middle x-ray, the far right one, we can get really good balance over all of those segments. And some docs like to do different technologies where they think that the mechanics of different discs should be at different levels for different reasons and different phases of the disease. I don't get that. I'm sorry. I try to find what I think the best technology is. We've all seen these horrible outcomes with our fusion technologies, and I think some of these are better to do compared to what we have done historically with fusions over multiple levels. Quicker, faster recovery. Patients can get back to do things that they really want to do and can be a great outcome. And it's an expanded indication. I saw this patient a year or so ago that had a huge 3-4 disc above a long construct. And the last thing I wanted to do was take his plate out. And I think, here, what am I going to do? Do an anterior decompression and fusion and distract it out. So I chose to actually just leave the plate there opened the space up, decompressed it all from the front. I got a post-op MRI. The posterior compression is gone because of the height, and put a disc in. And I think that's another alternative, no different than taking patients with multiple levels of disease that we can expand. But here's a classic example of what happens at the bottom if you don't do good techniques. The heels were too close to each other, probably too much milling. You can see that one fractured through the other, gave it the less than ideal overall outcome. So we can see that there's another technology like this that's very complex, and the M6, I have only played with it in the lab. I've seen some of the outcomes. I haven't personally used it as an experience. I got these from Rudy Bertinoli, where you can see some diffuse osteolysis over these segments, and that could be a combination of this artificial disc, the fixation, the teeth, and a variety of things. And so we need to look very carefully at all these. In summary, where are we at with total discs in the neck? I think they're improved outcomes in what we've done with fusions. They're quicker, faster recovery. I think you can maintain or retain motion. They are very complex biomechanics, and we've got to look at them all. And clearly, it's not as forgiving as fusion surgery, but it's not really a product. And I try to educate my fellows. It's a whole different philosophy of the way we can manage these diseases in different phases of the disease. But you really have to think about how each of these technologies fit, because it's a true philosophy and care, not just a product. Thank you.
Great job, Mike. Thank you. And great perspective. Self-advertisement. Please join us for our quarterly July 15, I think, spine arthroplasty conference. It's July 18 from 5 to 6 p.m. Pacific Daylight Time, and we have great speakers. Mike Janssen actually going to talk about lower dosing for efforts, and we have the first public report of Rick Sasso's 20-year follow-up of his disc arthroplasty experience. It's great to have Dr. Vincent Arlet here from the University of Pennsylvania. Vincent, you had some questions. Fire away.
Hi, Michael. Just congratulations. Great talk. Congratulations for your being a grandfather. Is it your child from Penn? Is it your son from Penn? Yeah.
Yes, my son finished he did a maternal fetal medicine fellowship for 3 years at Penn, and now he's staying on a faculty, and it's him. Yeah, they had a baby girl.
Okay, so congratulations. I got two questions for you. Regarding the disc replacement, do you have a threshold regarding the age and the BMI for your cervical disc replacement, or it just doesn't matter? Second question, in patients who have cervical myelopathy, you showed a few examples of patients who had cervical myelopathy where you put an artificial disc. When do you decide not to do a disc replacement patient with a cervical myelopathy, or either before the surgery or intra-op? You say, I just can't do it intra-op just to do a disc replacement, and you have to resort to do a fusion.
Great question. So number one, regarding BMI, I'm not as concerned as long as I can get good imaging, I hope, in the neck as I compare to the low back. So, sometimes it's hard to even see 5, 6, and 6, 7 in the neck. So in those patients, I put IV bags along their shoulders up to their ears so that the density is the same as the shoulder. So when I take the lateral, I can see perfectly 5, 6, and 6, 7. That helps me when I'm doing the patients with bigger or short necks and larger patients. Age, I haven't really. I look at their chronological, but what I think their physiological ages. I mean, in Colorado, I see patients that are 75 that are doing Ironman and stuff like I am, which is crazy. But if their bone quality looks good and they're that age, I still tend to do a disc in the cervical because I think it's a quicker, faster recovery. I'm much less apt to do that in the lumbar spine because they usually already have that facet disease and stuff too. Myelopathy. For me, if the myelopathy is due to a hypermobility because they got horizontal orientations of the facets or some set, and they got this hypermobility at the segment, especially at 3, 4, and 4, 5, I never try to do an arthroplasty because I think it's a big mistake, because then you're asking the implant to take up too much load. If the myelopathy is due to a large disc herniation or a spur that I can get out, but they don't have hypermobility and they don't have this real horizontal orientation of the facets, I would tend to do a disc. But today, I tend to like to put the MRI compatible disc in, which was a Simplify. Again, I don't have any conflicts on that at all, but I did run the trial, and because I like to take post-op images sometimes and see if there's still a signal change in the cord or if they don't get better. And I always struggle when you got this big artifact and you can't see. Some people could argue it doesn't make a damn bit of difference because who cares what the MRI looks like post-op? I just like to be able to look at it, so sometimes I do that instead.
Great questions. JJ has a question.
Hey, Mike. Great talk,
Yes.
as usual. So you've shown experience with so many different discs, and your studies have shown, and others, that they really are no never mind. They all play pretty much the same. But in your experience, after so many years, can you find a little thing where you say, well, I'm going to use this disc? Are we at that point where you could say, I'm going to use this artificial disc versus that artificial disc? So especially when you have hybrid models where you have a fusion, where you selected a total disc replacement for your wife, are you at that point where you say, no, I'm going to use this one because that disc is
Yes, I think that's good. Absolutely, I do. I think that, and when I do it above a fusion like that, I personally like I think more of a semi-constrained device where the polyethylene is fixed to the inferior end plate like the Pro Disc or the Globus device. I don't like the Mobi-C because I think it's got too much motion on it. That's my preference. I also like a keel prosthesis because it anchors it really well and doesn't move. And so those are the kind of things I look at. If I'm going to do something with 2 levels where I want to do post-op MRs, I tend to move in towards doing the simplified disc because I think it allows me to get great imaging. Those are the general categories of whether I want that mobile core completely in the polyethylene like the Mobi-C, or I want something that's more rigidly fixed. And I think of it like a teeter-totter where it's a hinge, where it's moving directly over that polyethylene, and I know exactly where the top of that polyethylene is exactly where I think the axis of rotation is, kind of like a basketball, and I want to keep it right on top of that globe, then I think I can control that segment better, especially over fusion.
Great question. Question by Dr. Farkbash, again, very insightful and elaborating on what Dr. Arlett asked before, and that is micromotion around cord injury. So if patients have had, let's say, a myelopathy, how wise is it to facilitate mobility around the cord if maybe there's a cord protection facilitated by fusing that damaged segment? So does micromotion around a damaged cord and myelopathy actually damage the cord further, or does it help the cord to just arrest motion at that segment?
Who are you asking, Jens, that question?
Yes. So is it, going back to the myelopathy question, how smart is it to actually do a motion-preserving surgery in the presence of myelopathy when micromotion may actually continue to damage nerve cells in the cord?
Well, I think it also depends on what the cause is. If you just have a lot of central disc herniation and you decompress that, and it's not been a long-standing phenomena, and the facets are not abnormal, I tend to still have been putting in arthroplasties in those, and they were not an exclusion during the clinical trial, at least in the Pro Disc and or the Simplified. But if it's due to long-standing, big osteophytes and horizontal orientation of the facet joints, and you've got a big signal change, maybe resting in the cord makes more sense. We didn't see that in the trials, but I am somewhat selective on doing it on a myelopathic patient. But it's only if they have a big recent central disc herniation that I take out.
Great. One more question from myself. Inflammatory arthropathies. I have a lot of patients who want to have disc arthroplasties nowadays. Is it wise in an RA patient or somebody who has, let's say, ankylosing spondylitis to actually do that? Should we be more diligent in selecting those patients out when we consider them for disc arthroplasties?
Well, my experience are failures. I mean, those are the worst problems I get when I try to expand. Somebody with some sort of a spinal arthropathy, been on long-term steroids, RA. It's just a disaster because you know.
Yeah, I fully agree. Well, thank you, Mike. Outstanding as always.